But one man every 45 minutes will die of prostate cancer in the UK. Prostate cancer, the way I explain it to people is it can go from being like a household pussycat to being a Bengal tiger.
Hello everyone, welcome back to Nadia's Lab. Today we are diving into something often overlooked but potentially life-saving, prostate cancer. My guest is Professor Prasanna Sooriakumaran, a consultant urological surgeon specializing in robotic surgery for prostate cancer. Prof, thank you so much for joining me.
Thank you for having me, Nadia.
I'm very honored to have you here. Can I just start by asking you to tell me a little bit more about your career and experience to date?
Sure. So I'm a professor of urology. I work academically at the University of Oxford, where I do some clinical trial work in prostate cancer. And I also work clinically on the NHS at University College London Hospital, and also privately at the Cromwell Hospital in West London, at New Victoria Hospital in South West London, at Liverpool Street Doctors Clinic in Liverpool Street, and also finally at Harley Street Specialist Hospital in Harley Street. So I have quite a few
A
different
lot.
jobs.
How do you find time?
Yeah. But I basically mix research at Oxford with clinical work on the NHS and privately, but all focused around prostate cancer and men's health.
Amazing. And what made you choose urology at first place?
So when I was a medical student, I quite liked surgery. I liked the dissection thing. So I always wanted a surgical specialty. And urology has a lot of toys. So you have the robot, you have lots of endoscopic things, you get to do open surgery, laparoscopic surgery, and robotic surgery. So I kind of quite like the ability to boys with their
Amazing.
toys kind of thing.
That's really
surgery.
impressive. And I wanted to get your opinion on this. When I started this podcast and working in hospital, I always feel like a lot of women approach me to say, I'm so grateful you're talking about, our health and, certain diseases. But do you feel like men are less likely to talk about their health than women?
Yeah, 100%. So often they come with their spouses or their partners.
They let them do the work.
They are dragged into the clinic by the women in their lives generally before they come. So yes, 100% that men are far less likely to talk about their health or far less likely to go and seek health. There's also this kind of machismo, feeling that you're invincible
Yeah.
as a man and you can't show weakness by going to see the doctor. And also when it comes to the sort of men's health things that I do as a urologist, a lot of them are in fairly sensitive areas, the genitalia, the prostate, erectile dysfunction, those sorts of things. So they don't particularly want to necessarily go and see a doctor about those things. So sometimes they feel a bit of a stigma associated with it as well, which is a shame.
And how do you help them overcome them?
I think you just have to make them realize that there's nothing that a man comes to see me with that I haven't seen 1,000 times before. So whether it's erectile dysfunction or premature ejaculation or other sexual health issues or, testicular pain or lumps and bumps or prostate problems, whatever it happens to be, they're not alone. There's thousands, if not more than thousands of men out there who've got similar issues. So I think it's just about making them realize that actually they're not unique, or there's nothing weird or wonderful about them. They don't need to be shy about it. This is what I do all day long.
Yeah, I think that's a very good piece of advice actually for everyone. And let's talk about PSA screening. So the screening for prostate cancer is PSA, which is prostate specific antigen. And for many years, it's been quite controversial because of potential of false positive results. So I wanted to ask you, as of 2025, what's your opinion on routine PSA screening?
Yeah.
And what are some myths around PSA screening that we should know
So
about?
just to clarify, at the moment, there's no national screening program in the UK for prostate cancer screening. There is a large trial called Transform.
Yeah.
That's a £40 million trial that's starting, looking at this very question about whether we should be screening for prostate cancer. I trained in the United States. I did my fellowships at Cornell and also at the Karolinska in Sweden. And both the United States and Sweden have national prostate cancer screening programs, but the UK does not, because it hasn't been deemed to be cost effective and for the reasons that you discussed, things like false positives, etc. But my own view is that men that are at risk of prostate cancer should be screened. And so that would be the personal view as a prostate cancer specialist, but not a governmental policy view. But men that are at risk would be men who've got a positive family history. So men who've had a father or a brother with prostate cancer, they have a double the risk of developing prostate cancer during their lifetimes. Black men have a double risk of developing prostate cancer during their lifetimes. And as you get older, you have an increased risk of developing prostate cancer. So my advice would be, if you're a black man over the age of 50, you should consider screening. If you're a black man who's got a family history, even from the age of 45 or even 40, you should consider screening. Whereas for white men, perhaps it's less important unless they've got a family history with a father or a brother. So the Transform trial, which is starting, will try to figure out what's the most cost-effective strategy to screen and who we should be screening. But if you have private healthcare and you want to get screened, I think you should consider being screened, because there is also very good evidence from studies in Sweden that if you know what your PSA is in your 40s, that will give you much better information about how your PSA changes in your 50s to determine whether you have a risk of prostate cancer or not.
Amazing. Thank you so much for that. And if the patient does get an elevated PSAs or a positive PSA test, what happens next?
So if the PSA is raised for that man's age, and or if it's raised based on what it used to be, i.e. with historic results for that man, then we would normally do an MRI scan. So it's a non-invasive test where you sit inside or you lie inside a scanner. It takes about half an hour, 45 minutes to do, and that will give us an answer as to whether or not there's a likelihood of prostate cancer.
Okay, that's very interesting. I didn't know about that. And I read somewhere, and again, this might be wrong, just wanted to see your opinion, that 1 in 8 men will eventually develop prostate cancer.
That's right, yeah.
And something even more fascinating, which I've heard from another doctor, and he said that if men were to live until age of 120, they would all develop at least microscopically.
Yeah, so the thing about prostate cancer is it's a very heterogeneous disease. So it's a very variable disease. So you have the majority of men that have prostate cancer will die with their cancer rather than from their cancer.
Okay.
So that's the sort of very old man who ends up with microscopic, as you call it, or very insignificant prostate cancer. But equally, it is still the commonest cause of death from cancer after lung cancer in Western men. So it is still also the second commonest cause of cancer death in Western men. So there are also very aggressive prostate cancers as well. So prostate cancer, the way I explain it to people is it can go from being like a household pussycat to being a Bengal tiger. And actually, it's very important to figure out whether you're a household pussycat or a Bengal tiger, or whether you're something in between. So it's a hugely heterogeneous disease. So just as most men who have it die with it rather than from it, still it becomes the second commonest cause of death. And 1 man every 45 minutes will die of prostate cancer in the UK. So during the length of this podcast, 1 man will die from prostate cancer in this country. So it is very difficult to determine whether you've got the household pussycat or the Bengal tiger variety of the cancer, and that's why you need specialists.
And that's why I guess screening is.
That's why screening is helpful, because screening will diagnose prostate cancer at an early point. But what we don't want is to diagnose a whole bunch of household pussycats, which will never cause any harm to the patient. And that's where you need to be a bit smarter about how you screen and how you interpret the results of the screening.
And I wanted to ask you, what happens if prostate cancer is detected at a quite late stage?
Yeah, so if you have prostate cancer that's spread outside the prostate into other organs, what's called metastatic prostate cancer. The obvious one in the news recently has been Joe Biden, the former president of the United States. He has presented with metastatic or advanced prostate cancer. There is no cure for that, because you can't just deal with the prostate because you've got disease outside. But the good thing about even that prostate cancer, it is very exquisitely sensitive to hormone treatment. So you can give hormones that cut the prostate of its fuel, which is testosterone, and therefore keep the cancer at bay and stop it progressing further. And that strategy can last many years. So it can last 5 years sometimes. It can sometimes even last longer. And so, for many men who have got very advanced prostate cancer, hormone therapy, sometimes with chemotherapy, sometimes even with radiotherapy. And I'm running a trial looking at the benefit of potentially surgery on top of those treatments to help men with advanced prostate cancer, can therefore allow the cancer to be kept at bay for sometimes up to 5 years.
Oh, wow, that's impressive. And I wanted to talk a bit about robotic surgery because you specialize in robotic surgery, and I find it like a fascinating field that I don't know much about. What does it actually look like in theater? And like, how
so we're now getting away from the kind of metastatic prostate cancer to the localized prostate cancer.
Okay, so
where
surgery
the cancer is confined to the prostate, and therefore if you remove the prostate, you can therefore effect a cure.
Okay.
Sometimes if it's just gone outside the prostate, you can go a little bit wider and also effect a cure. But you're generally talking about that kind of prostate cancer rather than more metastatic Joe Biden type prostate
Do you think
cancer.
so? Joe Biden, he can only be treated with hormonal treatment.
So hormonal therapy, sometimes chemotherapy. Occasionally there may be some role for radiotherapy to target specific areas of disease, but generally surgery is not used for metastatic prostate cancer. Although, as I say, I am one of the world leaders in looking at that in terms of a clinical trial perspective. But for the standard of care for surgery would be for patients that have got localized disease, or what we call locally advanced disease, where it's just gone outside the prostate. And then the conventional way of taking the prostate is with a big cut up and down the belly, what's called an open prostatectomy. The other way is to use chopsticks, laparoscopic surgery. But the newer way, the way that we've been doing it in this country for some years now, and in the United States really since the early 2000s, late 90s, early 2000s, is using the robot.
Okay.
And the way
how does that
work? So the robot is like a big device. It has like a bit that docks onto the patient through sort of laparoscopic ports, and then you sit at a console as the surgeon, and you sit down looking into a device which has got three-dimensional stereoscopic vision, and you move your hands in hyperspace, and the robot on the inside moves in hyperspace.
Oh, wow.
So it's a bit like playing the PlayStation, and you're sitting here with a joystick controlling here, and something's happening on a screen over there. But here you're sitting operating here, and the robot is mimicking your movements inside the body. So it's a master-slave platform. So the robot is not autonomous; it's not doing anything on its own. It just, as you move your hand like this, the robot inside the patient will move like this. So if you've got a piece of diathermy or scissors and you cut like this, the robot will do the same thing inside. So it's a pure master-slave platform, mimicking what the surgeon is doing inside the body, and the surgeon's doing it outside.
And but is it more precise? Has it
far
changed
more
the
precise,
outcomes?
far more precise, because it gets rid of the tremor of the surgeon. Number one, it allows what's called 7 degrees of freedom. So the robotic hand can move round and around and round, much more than the human hand can move. And it has much better dexterity because it's got these things called endoristed instruments, so like the human hand. So when you do laparoscopic chopstick surgery, it's only in 2 dimensions. You've only got 2 degrees of freedom. The instruments have not got that same level of flexibility and versatility like the robotic instruments have. So you get much better dexterity, and also when you're sitting at the console you get times 10 magnification, so you can see things much clearer, and you're getting rid of the tremor. So you've got much better vision, much better dexterity, and that of course will result in much more precision in terms of how you can operate, which of course means that you get much better outcomes for patients in terms of cancer control, but also in terms of fewer side effects and better functional outcomes for patients in terms of recovery of their erections or their potency or whatever it happens to be.
Amazing. That's really impressive. And how do you decide between surgery, radiotherapy, and active surveillance?
Yeah, so the thing about localized prostate cancer is there are different options again. So some men can have surveillance if they've got the kind of the house or pussycat type prostate cancers that don't necessarily progress very quickly. They might just watch it. That's called surveillance. That'll be with regular scans.
Like watchful waiting?
Yeah. Watchful waiting is slightly different, but active surveillance is the regular scans and blood tests. Watchful waiting is done for men who've got advanced cancer, but are unlikely to die of it because they've got other medical problems like heart disease, whatever, or they're very old. And if you just want to keep an eye on things. But active surveillance is where if they then needed something, you can then act with surgery or radiotherapy. Okay. So that's one option for localized disease. The other option is to treat the localized area of disease with just what's called focal therapy, where you can just zap the area with high intensity focused ultrasound, or freeze the area with cryotherapy. Sometimes you can use lasers like photodynamic therapy, or nanoknife, which is a kind of precision way of targeting just a specific area inside the prostate. Those are sort of focal therapies. The problem with focal therapies is that their recurrence rates are very high, sort of 25% within 5 years. And
Okay.
then if you then need to do surgery afterwards, the outcomes are significantly worse in terms of erections for men. So we ran a large trial at University College Hospital, collaborating with the chief investigator was at Guy's Hospital, and we showed that actually these men don't do so well after surgery if they've had focal therapy beforehand in terms of things like their
Okay.
erections. So that's generally done for perhaps for men where you don't think they're likely to need a further treatment down the road.
Okay.
But the definitive kind of most curative forms of treatment would be either radiotherapy to the prostate or surgery to remove the prostate.
Okay.
And so you will the choice of those things will be based upon what's important to the man in terms of side effects. So for example, radiotherapy may have less side effects on things like erections, on things like incontinence compared to surgery, but radiotherapy is given with hormone therapy, which can cause lots of other side effects like breast swelling, breast tenderness, um, things similar to the menopause, what we would call the
Yeah.
andropause, putting on weight, mood swings, you know, bone, bone weaknesses. Those sorts of things can all happen with the hormones on top of the radiotherapy, whereas of course not with surgery. And also waterwork symptoms can be made worse after radiotherapy. Bowel symptoms can be made worse after radiotherapy, which doesn't happen with surgery. And radiotherapy can very occasionally also cause second cancers in the bladder and the bowel, which again doesn't happen with surgery. So generally radiotherapy is used for older men. The average
Okay.
age for radiotherapy for a man with localized prostate cancer is 77, whereas for surgery it's 10 years younger. So generally younger, fitter men will choose surgery,
Okay.
and older, less fit men who are not fit for a major operation will choose radiotherapy.
Fine. Thank you for that. And if this is a bit of a creative one, but if we had infinite money,
Yes.
no boundaries,
That'd be lovely, wouldn't
that
it?
would be lovely, no red tape, what would be the dream surgical setup for prostate cancer? Or do you think that's already happening with robotic surgery?
So I think robotic surgery has made a huge difference in terms of the outcomes we can get for patients. So I've operated on well over 1,000 men now
Oh,
with
wow.
robotic surgery for prostate cancer, and the vast majority of them are doing really, really well. They've got negative, no signs of recurrence from their prostate cancer.
It's impressive.
They're living normal lives. They're not incontinent. They may need help with their erections, but they're able to have sex and live fulfilling lives. So they're all very, very happy generally. So it has made a big difference. But I think there's always room for improvement.
Yeah.
And there are certain technical modifications that we are still looking at with robotic surgery to refine the operation further. So something called rectus sparing prostatectomy, where we don't have to damage the bladder or move the bladder out of the way when we do the operation, allows us to get better continence outcomes. The men don't need to wear pads or nappies after surgery. That's been a major advance. Various things like various nerve sparing techniques that we can do as well
Yeah.
can help with erections after surgery. So that has also had a major positive impact on quality of life for men after surgery. So there are certain
Things that
technical
can
modifications that we're
improve.
still doing that can improve things. And then, of course, in terms of efficiencies, in terms of throughput between theatres, having more than one theatre running at the same time, having, different teams of staff in different places, a bit like a Formula One pit stop, where you've got different people working in different places to try and speed things along to improve efficiencies. The things that we're looking at within the NHS to try and improve the amount of cases we can get done in a day or in a week to help with waiting lists, because prostate cancer is now the commonest cancer in England, full stop, and therefore the numbers of patients are rising and rising and rising, and therefore we need to, as well as improve the operation, we also need to improve the efficiency and the throughput, especially in a resourced healthcare system such as the NHS.
True. Yeah, I agree with that. And we talked about a bit of side effects, and I think we can agree on erectile dysfunction being a big one for men.
Yes.
So I wanted to ask, so there's erectile dysfunction, there is gynecomastia, which is the enlargement of breast tissue in men. There's also incontinence. So so it's both the prostate cancer itself and some treatments that can lead to those.
Yes.
How do you kind of have this discussion with patients and, help them maybe deal with this side effects?
Yeah, so the side effects of gynecomastia is generally from the hormone therapy
Okay.
rather than the cancer itself. And the side effects of erectile dysfunction and incontinence is generally from surgery rather than the cancer itself. So the thing about prostate cancer is when it's localized and curative, it generally curable, it generally doesn't have any symptoms. And so that's why it becomes even more challenging, because sometimes men are like, they come to you and they've got no symptoms, and yet you're going to do something and give them some side effects.
Yeah.
And that's difficult for them to sometimes get their head around. But it's very important, because otherwise the cancer can progress and then can cause them their demise. So it is important that they get checked early and then they get dealt with early. But there are lots of things we can now do about side effects. Okay,
Yeah.
so in terms of hormonal side effects, if they have to need hormones because they're having radiotherapy or because they've got advanced cancer, and they need hormones as part of their treatment for that, there are certain things that we can give them that will help with those side effects. So things like for hot flushes, they may have things like tamoxifen or whatever that can help with that. To be honest, exercise has been shown to be a huge help for men who are on hormone therapy in terms of helping with side effects. There was a recent article produced that showed that that exercise reduced the risk of colorectal cancer coming back.
Oh, wow.
Of colorectal recurrence, and we're now doing studies to see if that's the same in prostate cancer.
Amazing.
But what we know is that actually it really does combat the side effects of things like hormone therapy. So resistance training exercises are really helpful for men who are on hormone therapy. So that's one thing that we can also do. In terms of side effects from surgery, things like erectile dysfunction, of course, there are tablets that can help, and there are things such as vacuum pumps and sometimes injections that can also help. So it's not that they won't be able to get erections again. The vast majority of men can get erections again. It's just that they need help in order to get those erections again, typically. In terms of things like incontinence, generally things like pelvic floor exercises, what are called Kegel exercises, the same things that some women do after giving birth to children, those same things, exercises men can do. And one of the things that I have done is I worked with a company called Avogen Health, which and we created an app, a digital app for men undergoing robotic prostate cancer surgery to help with their recovery. So it goes through things like their mental health, it goes through things like their continence, it goes through things like their erections, it teaches them what they can eat, what they can drink, because things like caffeine should be avoided, alcohol should be avoided in the early recovery phase, how much activity they can do, when they can swing a golf club, what golf club they can swing when, whether it's a 7-iron or a driver, whatever. All of those things we've put into this app, which men are now using, and it's freely available. It's not commercial.
What's
they didn't
the
make
name of the app?
any profit from it. It's called Pro Recover. Pro-recover. It's available on on the Google Play Store. It's available on the App Store, and we created it free for men because, again, one thing I noticed is that we've become very good at doing the operation, but perhaps what men want and what patients generally want is to be able to direct their own recovery and manage their own symptoms. So it has things like a step count, it has things like a red flag thing if they develop certain symptoms, it allows them to track their pad use, all of these things in real time, as well as educates them on, as I say, on things like their mental health, their continence, their erections. And they found it very useful. So generally speaking, I direct men to use that app if they're having prostate cancer surgery.
That I haven't heard of that app, and I think that's brilliant. So what's something that really excites you in the field right now, like a new drug or technique or diagnostic tool? I think we touched base on it.
I think what excites me now is how much better we are getting at diagnosis for prostate cancer. So in terms of surgery for prostate cancer, I've been a leader in that field for some years, and I'm involved in some of the innovations we talked about, like rectus sparing prostatectomy and some of the graded nerve sparing techniques, and I've published papers on that. And I'm also doing a lot of work looking at men with metastatic disease, advanced disease, and the role of surgery in that. So I'm involved in all those sorts of disease areas and improving the treatments. But I think the other thing is the fact that we're much better at diagnosing prostate cancer than we used to be. Some of my colleagues at the University of Oxford, where I'm an academic, published a trial called Translate recently, which showed that there's a better way of biopsying than the old-fashioned way of sticking a probe up the back passage and taking samples of the prostate. It's what's called a transperineal biopsy. And we've now moved on to doing something called fusion transperineal biopsy, where we actually get the MRI scans contoured where the potential suspicious areas are, and they're put in at the time of biopsy onto the ultrasound machine, and we kind of get an X marks the spot where we can target accurately where the potential prostate cancer could be.
Crazy.
And so our level of accuracy is much better than it used to be. And one of the new private hospitals I'm working in, or it's not a new private hospital, it's new to me because I've just started working there, is the new Victoria Hospital, and they were very good. They got this new fusion biopsy kit immediately as I started working there, and I did the first cases of those fusion prostate biopsies in that hospital recently, and I've got another 3 to do next week. So we are now in a position where we can offer much more targeted, much more precision diagnostics, which is much more accurate, but also has much less side effects for men, much less risk of infection, much less risk for urinary retention, and as I say, much less risk of missing potential tumour as well. So we've now got much better diagnostics as well as much better treatments. And so really the future for prostate cancer is looking really bright. We're curing most men. We're picking more and more men up early than we were in the past. We're starting to look at screening and looking to see who we should screen and when we should screen and what's going to be most cost effective. And so actually I think, we're really kind of winning the battle against prostate cancer.
I love to hear that. Thank you so much. And do you think that primary care doctors should get better, or how can they get better at referring early?
Yes, I think it's challenging because primary care doctors have to deal with loads and loads of things, right? I only deal with, in my NHS care, I only deal with prostate cancer, and privately I deal with men's health and predominantly again prostate cancer. So it's much easier for me as an expert with a PhD in prostate cancer robotic fellowships, prostate cancer experience, thousands of men treated, etc., to know about prostate cancer, because they have to know about hypertension and obesity and gynecological things and asthma and everything else, right? But I would say, if a man presents with low urinary tract symptoms, they should have a PSA. If a man has risk factors and is of a certain age, in their 40s and above, they should have a PSA.
Okay.
If a man has any concerns because of family history or whatever other things, they should have a PSA. If there's any doubt, they should come to a urologist who can then assess their need for an MRI scan, and then based on that, they need to do a precision fusion prostate biopsy that we've just talked about. Get that done, get an idea as to whether there's any cancer. If there is cancer, how aggressive that cancer is down the microscope. Does it look like the household pussycat, what we call a Gleason 6? Does it look like a Bengal tiger, what we call the Gleason's 8 to 10s? Does it look like something in between, what we call the Gleason 7s? That gives us an idea of how aggressive the cancer is, how much potential it has to spread. Also, it'll tell us, the biopsy will tell us how much cancer there is within the prostate. Is it just got a tiny amount of prostate cancer, or is it the whole prostate full of cancer, or something in between? And then we can do various staging scans like PET scans to see if there's any sign of spread of the cancer outside the prostate into the surrounding structures like the seminal vesicles, the lymph nodes, the bones, etc. And so once you have an idea of whether there's cancer, how much cancer, how aggressive the cancer, and where the cancer has got to, you can then make decisions about treatment, whether they should have surgery, surveillance, or focal therapy, radiotherapy, hormone therapy, chemotherapy, etc. So there's a huge variety, which I would not expect general practitioners to know about. What I would expect general practitioners to say is, okay, you've got a risk of potentially having prostate cancer. Let me send you on to a prostate cancer specialist.
Fair. And I've read some studies that obesity has been linked with prostate cancer, but I mean, obesity has been linked with a lot of different types of cancer. So what's your thoughts on that, and what's your take on nutrition or lifestyle change for prevention?
That's a really good question. So, unlike with many cancers, smoking hasn't been that associated with prostate cancer, but interestingly, a Western diet and a Western lifestyle have been very much associated with prostate cancer. So diets high in animal fats, low in fresh fruit and leafy green leafy vegetables. Those have been associated with prostate cancer. Obesity, a sedentary lifestyle. So what you want is people to exercise, eat healthily. And when I say eat healthy, I mean what is good for your heart is good for your prostate. So avoidance of saturated fats, avoidance of too much animal meat, avoidance of too much protein without enough green leafy vegetables, there are certain specific chemicals that have been potentially hoped that have some data to support them as preventative. So things like ECCG, which is found in green tea, lycopenes found in tomatoes, are thought to also help in prevention. But basically, you just want to live a healthy lifestyle, exercise well, eat plenty of fresh fruit and vegetables, avoid too much saturated fat and animal fat, and that will help reduce your risk of prostate cancer.
Amazing. Other than that, any other advice for men watching this? I mean,
so I think the biggest thing I would say is to be proactive, because prostate cancer isn't without symptoms until it's got to a later stage. Once it's got to a later stage, the man presents with bone pain, except they've usually got metastatic disease. In the early stages, it can be completely asymptomatic without even any waterwork symptoms. And so the best way to pick up prostate cancer is to be proactive about it and to get screened at an earlier stage by having a blood test like a PSA, potentially having a rectal exam by a urologist, going and seeing an expert prostate cancer specialist like someone like myself, who might consider an MRI scan. Remember, the MRI scan is also very operator dependent and depends on what sequences they get done. So again, you need to go and see a specialist to decide on whether that's required, and then how to interpret that, and then how to do the biopsy. Whether you have a fusion biopsy or the old-fashioned biopsy makes a big difference as well. And so that's where seeing the right individual, the right expert, makes all the difference.
So, Prof, apart from your work in NHS and clinics, you have a variety of portfolio and you work in tech and clinical research. Can you tell me a bit more about that, and also how can maybe young healthcare professionals get to that stage, and what advice would you give for them who want to pursue a career somewhere outside of hospital as well?
Oh, absolutely. So you're absolutely right. So as well as being a urologist on the NHS and privately at these various private hospitals, I'm also a clinical academic at the University of Oxford, where I'm a visiting professor, and I'm involved in clinical trial work, all to do in prostate cancer and the role of surgery in various aspects of prostate cancer, various stages of prostate cancer. So that is very interesting. But I think it's very important, or for me at least, it's very important that I can help patients in more than just an individual way by seeing individual patients clinically, and more than just perhaps changing things potentially many years down the line with research. There's a lot of things, other ways we can help patients, and part of that is through health tech consultancy work. Part of that is through creating things like digital apps, as I mentioned earlier. I do with a company called Average Health, where I'm the lead for urological innovation. I also started work a little while ago with a company called Oncoflow, where they're involved in artificial intelligence, and we're looking at how we can do that in prostate cancer to help with standardization of uropathology, uroradiology, clinical decision-making tools. I'm hopefully going to start working with another company called Emerald to look at that in more detail and move on from Oncoflow to Emerald to do that. There's also work that I do with a company called Linda's Health, which is a CRO, a contract research organization, to try and run clinical trials in a much radically faster way than what we usually do in universities, and to work more directly with patients in that. So I think there's lots of different things that now as specialists we can do. In the old-fashioned days, when my father was a doctor, he still is a doctor, but as a practicing doctor, when he became a consultant, it was just get an NHS job, and in your free time do a bit of private practice. And that was all you would do. Whereas now, you've got the research as well as the NHS work, which is great. But as well as that, you can do consultancy work. I do some consultancy work for a variety of companies. I work with some private medical insurers to help with their pathway development and with their virtual platforms. You can also do work for the college. I work also for the Royal College of Surgeons as an invite reviewer, where we can go to different departments up and down the country to help with their urology pathways and their urology services. So you can do lots of different things these days, and I think it's very important that whatever you do, you triangulate around your interest.
But do you feel like it does require a few years of experience of working with patients, working in hospital, before you're offered all these opportunities?
Yes, I think
it might be a bit difficult for a junior doctor, I feel.
Yeah, I think if you're very junior, so if you're straight out of medical school or at medical school and you want to do something, it's a bit more challenging. I think it's really helpful to have that breadth of experience. I have that breadth of experience. or that length of experience, not only in the NHS, but also in the private sector, where I was the lead for urology for Cleveland Clinic London. I'm now the lead for urology and men's health at Harley Street Specialist Hospital. I have leadership, I've held leadership roles, in clinical services. And so that helps. And I think having 20 plus years of experience helps.
Definitely.
Working as a clinical doctor and also working as an academic. But you can do something in between. You can be a sort of, registrar level. So you've had a few years of experience working in the hospital and you've got an idea that you want to fly with, because most of these sort of startup companies that I've been working with are run by doctors at that level, not at doctors at my level, because they're actually, doctors at my level are kind of, past the kind of curve of understanding how to use technology and AI and all of these things. And the clever people are all more your age. So, I think there's that sweet spot where you can be sort of 5 years into clinical medicine and then do something. Or you can, as I say, wait till you're much more senior and then provide more of an advisory role to a variety of different institutions and
But do you feel like a lot of consultants and people with a lot of experience, they might be a bit reluctant to use all this AI and technology and tools? I remember from working in a hospital, especially in clinics, like I would go to rest clinic every Friday, and some consultants with incredible experience and knowledge, they would hate the systems, they would hate any changes.
Yeah, they don't want
so good with technology.
They don't even want to use electronic health records. They just want to use paper and stuff.
Exactly.
But that's life, isn't it?
How do you adapt to it so quickly?
Well, I think, you need to have that growth mindset and that improvement mindset. And you also need to be very patient focused and patient centered and understand what's better for patients. It is much better for patients to have an electronic health record, which you can then utilize to get audit data out of, or for governance purposes, or for research purposes, where they've got everything in one place and you can liaise with different specialists about, rather than you filling out individual pieces of paper. So if you think about it, what you would want as a patient and what is best for the patient, you would have to realize that you need to adapt yourself to do that. Of course, we would all like to just do what we are very good at doing and not have to change, not have to grow. It's much easier for me just to manage clinical patients with urology or prostate cancer problems, because I can do that in my sleep virtually. And I'm a world leader in doing that. So that's the easiest thing. It's much harder for me to say, well, actually, there's a gap in the market for developing, for men's recovery after prostate cancer surgery. Let me go and work with a med tech company and work with software engineers to develop an app, when I had no experience in doing that. But I understand that that's what's best for patients. So then I went off and do that, or understand that actually, clinical trials, the conventional way of doing clinical trials takes ages. So actually working with a company like Lindus Health, where you can deliver clinical trials and oversee clinical trials that are being delivered much quicker, and provide that medical expertise, that urological expertise in clinical trials that are being delivered quicker, would be helpful to do that. So I think it's understanding that if you put the patient first at everything that you do as a doctor, then you have to adapt. You have to adapt to AI. You have to adapt. Otherwise, we'd still be doing, in prostate cancer, we'd still be doing big cuts, and we never learned to do robotic surgery, right? In 2009, when I decided as a first year registrar that I wanted to become a prostate cancer specialist, I did a PhD in prostate cancer, I realized that the future was going to be robotic. So that's why I decided to go to the United States, do my USMLE exams when nobody else was doing that. I think I was the first urology trainee that went to the United States to learn to do a robotic fellowship. It was very challenging in those days, because you had to go off and do all your USMLEs, as well as your FRCSU role, as well as everything else, as well as live in central Manhattan for $30,000 a year, savings, etc., taking out loans, all of that, leaving family, friends, whatever. But if you recognize that that's what's better for patients, robotic surgery is going to be what's better for patients, then you go off and learn that. In the same way, you recognize that AI is going to have an impact. You recognize that you need to help patients by running clinical trials faster. You need to improve services by joining the college and providing oversight in urology services. So these are the things that you can then do. So I think if you are patient focused, and if you think about the patient's experience and what's best for patients, you can understand that you can help patients in other ways than just direct clinical care.
Amazing. And where can patients learn more about you and your work? Is there, have you got a website?
Yeah, so I'm in the process of creating a website. So
Okay.
hopefully in the next month that'll be available. But a simple Google search for my name. I feature on the website for the University of Oxford, University College London Hospital, the New Victoria Hospital, Harley Street Specialist Hospital, Liverpool Street, Doctors Clinic Healthcare, the Cromwell Hospital, Bupa. So if you type my name into Google,
It will come up.
you'll find lots of different websites that feature my name. But in the next month, I'll have my own website.
Amazing. Prof, thank you so much for joining us today, and thank you for sharing your incredible insights in robotic surgery and prostate cancer care. It's really fascinating to see how much we've improved and how much technology has helped us and really helped improve quality of life for prostate cancer patients. And to our listeners, I hope you found this as eye-opening as I have. If you're interested in robotic surgery or know someone going through prostate cancer, do share this with them, because knowledge is really the power. I release episodes every Tuesday, so make sure you subscribe and get in touch with me on LinkedIn and Instagram and let me know of your thoughts of this episode. Thank you so much. Bye.
Thank you so much.
Thank you.
Thank you.